Okay. Is Cynthia on or is having technical difficulties still?
No, I think I'm better now.
Okay, go ahead, Cynthia. You can do the intros then.
Okay, good morning, everyone. I think we're all really excited to hear this talk by our transplant psychiatry team. I actually will let maybe Susan Abbey do the introductions if she doesn't mind.
I'd be delighted, Cynthia. And I'm really excited. 36 people have come. I was kind of scared nobody might. But we were going to do our standard sort of talk for you. I was all excited about eating disorders and transplant patients because we've seen several cases recently. But as we talked about it, Adrienne Tan and Carla Garcia, who you both know and who are taking part today, were much wiser than I and said, really, we want to do this? Like everybody is completely burned out with the third wave. And why don't we do something that might potentially be helpful and talk a little bit about what we do know about kind of what people are experiencing now. There's a kind of a phrase in therapy that says that if you can name it, you can tame it. And another similar one, if you can feel it, you can heal it. So the sense that a lot of us feel just very shut down, that maybe if we could sort of talk about some of this, we might be able to start to move forward with it. So if I can, Adrienne's done the slides for us. If you could just go to the next slide. We have no disclosures related to this presentation, but what we really would like is your feedback about this. As we started to put this together, we sort of wondered if this might be helpful for other areas as well. And so please feel free to just be brutally honest, whatever you want in the chat. Anna is going to separate the chat out so that it won't like live forward. You know, that the presentation itself will be can be disseminated, but your name beside any comments won't be. So feel free to give us comments about that and what's helpful and what's not with this, because that'll help us help other people. The other thing, we're going to use the chat function for some reactions to a couple of segments of this. And again, you know, you can feel free to put things in the chat. It won't appear again anywhere else. I would ask people to, if they're going to, you know, if we're playing along and people are writing things, to just, you know, tell other people what you experience, but don't say what anybody else has put in the chat. And then if we can just go to the next slide, we've got our learning objectives. And so we're going to try to do a couple of things today. We want to talk a little bit about the literature on the mental health impacts of COVID on healthcare professionals, and examine the cumulative grief that has really been experienced secondary to the pandemic. We're going to talk about an approach to working with the grief to foster a flourishing rather than languishing. And some of you will have seen the New York Times article a couple of weeks ago about how a lot of us feel like we're languishing. And we're going to do two very specific mindfulness exercises that will hopefully help us in naming kind of what our challenges are now in sort of being healthcare professionals, having been through this period of COVID, and also in starting to move forward. So that's the plan for today. I always say to people, I'm going to start, if we go to the next slide, I'm going to start with a meditation. And I'm going to ask people, you can play along or not play along. So you can turn off your camera, you can make your grocery list if you want, or if you want to play along, and just do whatever you want. You can sit, you can stand, close your eyes, open your eyes, whatever feels best for you. And just starting by taking a moment to just feel your breath as it comes in. Noticing, do you breathe through your nose or through your mouth? And noticing what sensations you can feel in your chest. Do you feel it rising or stretching? What's that sensation like? And then we're just going to take a moment to try to bring to mind some situation from the COVID times that we have carried with us. So it might be something big, or it might be something small. It might only be, just a minute or two interaction with somebody, but it stayed with us. And that's why I call it sort of, trying to notice what the sticky part of it is. Why does it stay? What happened? Was it a feeling of fear or expectation, conflict, uncertainty, sorrow, some harm that we felt we caused to ourselves or that we did to someone else? I'm trying to get an example. I always say it's a little bit like weightlifting. You start with the 2 kilo weights, not the 20. So if it's something really hard, put it aside and get something a little easier to work with. Just sometime that was really hard. Anthony Black, who's an internist in palliative care in Seattle, said at a weekend workshop I was at that really that we have been through multiple cascading traumas since last January or February of 2020. Sort of started with all the wildfires in Australia and California, COVID coming. It exposed all of the terrible things in our long-term care system. George Floyd, the inequalities in our society, the overrepresentation of the marginalized and Black and brown people in our ICUs, and the struggles that some of us have around, who am I now, and what have I become, and how can I be a good healthcare professional now? Did I do enough? Did I do the right things? And all of this happening in circumstances beyond our control. And just taking a moment to notice kind of what is that sort of sticky part, what holds you, what's hard to work with, what's unresolved, what's incomplete. And just know it for a moment and know if you feel it in your body somewhere, if you feel it in your emotions, if you feel it in kind of the chatter of your mind, and just trying to hold that experience with a kindness and a respect. These have been really challenging times. And seeing now if you can come up with a single word or phrase that would name that unresolved part, that sticky part, and what it represents to you. And it does take some courage to acknowledge some of this, but if you would kind of open your eyes, and if you're comfortable, just putting a word in or two or a phrase in the chat that describes the sticky parts for you. And again, 100% promises this is completely confidential, and we'll just try this afterwards. So what's been hard for you?
And I will read them out as we go, just so we get a sense of what we're all experiencing. So hope, stress, sadness, an overwhelming feeling of sorrow, never ending, fed up, mental exhaustion, isolation, exhaustion, isolation. So again, we pick up themes, and there's a lot that's said more than once.
And I think really just acknowledging the courage to put some of that out there, and that being really specific about these things is our first step in coming to terms with them, and to starting to heal them. We're going to talk a little bit more about this as we go along, but the brain has a very strong negativity bias, and it keeps us resting in narratives that are depleting for us. And if we can name our challenges, all of these: helplessness, exhaustion, isolation, injustice, suffering, all of those are forms of suffering. If we can bring that into consciousness, then we have the opportunity to metabolize it, to kind of move it through our minds and our bodies, because often it is locked in our bodies, and move forward. So the last thing I would like you to do, and you can turn off your camera if you want to do it or not, but to just take a moment to like shake or stretch and just see if you can kind of move. That helps to just sort of move some of the heavy feeling. So you can move some of that heavy feeling out, and then we will turn it over to Carla.
Okay. So I'm going to take the first stab at trying to put a name to this thing that we've all been experiencing in different ways. And I'll warn you in advance, I had some formatting trouble with with sticking in my references, but they will be available after this talk. I'll send them all en masse. So Adrienne, if you could go to the next slide. So does this sound like you? And so what I want is if everyone can just take a minute to read as we're going to go through this list and think, have I had 2 or more of these in the last 6 months? So frequently thinking about circumstances or consequences of a loss. It doesn't have to be a bereavement, although it could be that, but a loss. A recurrent feeling of disbelief or inability to accept this loss, persistent feeling of being shocked, stunned, dazed, emotionally numb since the loss, and recurrent feelings of anger or bitterness about that loss related to the loss. A persistent feeling or persistent difficulty trusting or caring about other people, or feeling really, really envious of others who haven't experienced or who you think haven't experienced a similar loss. And often when this happens, we'll also experience intense emotional or physiologic reactivity when we're reminded of the loss. So our bodies may feel it in some way when something triggers that loss. Avoiding reminders of loss, or excessively seeking out to try to replace what was lost. So if you think about all of those and ask yourself, have I had any of that, 2 of these in the last 6 months? And if you have, then essentially you meet criteria for complicated grief. And this is a DSM, so a Diagnostic Statistical Manual, psychiatric diagnosis. And one of the first things that came up very quickly in my review of the literature of this was that this is overwhelmingly something across all parts of the world that healthcare providers have really been experiencing, but it's also something that we share with people who not necessarily have been on the front lines. There is a global collective experience of grief out there in the world right now. So next slide. So what is actually happening to us then? And again, now here I'm going to specifically speak about us as healthcare providers. There we go. So across the world and across different healthcare systems, there is this pattern emerging. There have been a lot of individual sort of samples of assessments of people, of data collection of healthcare practitioners in different areas. And then there's been a lot of efforts to do systematic kind of reviews or scoping reviews. And overall, it doesn't matter where you are, the rates of psychological distress are very high right now. Interestingly, these have not gone down, even though the picture has improved so far. And around 70% seems to be where many of us are at. Things that are particularly prevalent are things like sleep disorders. More of us are having somatic symptoms, so physical symptoms of emotional distress. Things like acute stress disorder and post-traumatic stress disorder are starting to emerge in this population, especially those who have had repeated exposures to some of the traumatic things. We're going to talk about that in a minute. There's been more suicidal ideation and self-harm. You've probably read in the media that there has also been more completed suicides, although we're still sort of learning about that in healthcare providers. And there's this direct relationship with frontline exposure and risk of symptoms, right? So if you're in an acute care hospital, if that's where you work, then you are already in the highest category of risk for having some of these symptoms, or in some systems in the equivalent of a long-term care facility, if that is a thing that exists where you're practicing. And the highest risk category are females, usually younger females, and usually in the profession of nursing. And again, that probably is about exposure to that kind of repetitive trauma of being right at the bedside the most of all of the professions. The other thing that's was, I don't know why this was a surprise to me, but it was new. I hadn't seen this before, was that at the same time that all this is happening, you also are having all of these associated social risks. And some of us have already experienced this, you know, so people in the healthcare professions are having more income instability. Often there's a partner who's not earning what they were before. You've also often lost relationships you counted on to provide support for yourself or for your kids or for your family, or your caregiver burden has gone up elsewhere in your support system. There's more isolation. Many of us, especially at the beginning, would self-isolate from our families because, you know, we were being exposed in one way or the other. So these two things are happening at the same time. So if we go to the next slide. So we've actually been here before in the sense that as a profession, as a group, we have talked about what happens to us when we're under these intense experiences of stress that are prolonged. So about a decade-ish ago, we started talking about and studying something called compassion fatigue. And what I want us to look at is really just how these symptoms, where symptoms overlap, because it kind of gives us an idea of what happens when, as Susan said, our brain gets into this negative resting state. So compassion fatigue is something where we'll often have a sense of numbing, of dissociation, of disconnect. We tend to avoid situations where we predict that someone's going to be suffering. We might have intrusive thoughts or memories about it. We often physically feel uncomfortable when we're in the face of distress in a way that's different, that's more intense than it might have been before. And this is a very uncomfortable thing to happen. And the main price is one that we tend to pull away from folks or our supports. We tend to self-isolate. That tends to blend into something called burnout. And if you look at the symptoms of burnout, this is where it starts to, you start to see the pattern of the distress kind of turning more inward and it becoming more about you, a story about you. You are ineffective, you're dissatisfied with your work, you're detached, things don't matter, you become less interested, can't concentrate, withdraw more socially. And it's in the burnout people, the people who are experiencing burnout as this is described, that we start to have higher rates of not good outcomes in terms of care. So in other words, it affects our care, the ability of us to care for people. We have more troubles, including concerning things like, you know, higher risk of medical errors and less patient satisfaction with our care, and also more harm to ourselves. And the extreme of this, where we all hope we never end up, is somebody who has a mood disorder, like a depressive episode. And again, I sort of put in the symptoms there just so you can sort of see how the spectrum goes. And of course, somebody with a depressive episode is really going to struggle to look after themselves, let alone be able to function in something as intense as a healthcare environment. So if click to the next slide. So we've been here before, and yet at the same time, this is totally different. there hasn't really been in living memory a situation exactly like the one that we're in now. And one of the things that you're going to hear us talk a lot about today is the idea of cumulative grief or cumulative trauma. And that's something we've really had a lot of opportunity to learn about this year. One of the things that's important in terms of predicting whether you're going to be able to weather something like compassion fatigue and get out of it before you get to something like burnout is whether you have enough built-in resilience. And that's a lot about, you know, you and your sort of personal ways of coping, your adaptation strategies, but it also has a lot to do with the resources around you and the resilience of your system, right? Do you have lots of supports in your network? Do you have a little bit of socioeconomic bounce so that you can tolerate something that's, you know, difficult for a little while without being in major crisis? And when you have cumulative blows, then both your internal psychological structure, your social structure, and also your physiologic structure just can't take it. And I think in particular in transplant, we understand that fundamentally. We see it in our patients is, you know, there's only so many rows of burdens that a patient or their family can carry before we really start to see a real fragmentation of this person and their system and their ability to keep moving forward. So this has been one of the biggest challenges for us as a world, but particularly healthcare providers in the last year. Okay, so I think that's my last slide. So I'm going to hand it over to Adrienne, who's going to tell you now a little bit more about, you know, so what do we do with this? We find ourselves in this position. How do we move forward?
Thanks so much, Carla. I wanted to reiterate something that Susan had started with, which is so important for us in mental health. And that's that if we can name it, we can tame it. And if you can feel it, you can heal it. And I know, you know, you can think about it and say, well, does it sound a bit trite? But I think it's actually really important that, you know, in busy careers, as we do have as health professionals, finding moments of stillness are rare, to take stock of where we are and how we're feeling. And because we are in a caring profession, we are, you know, acculturated to defer our own needs in the service of others. And that is really, really beneficial when we're caring for our patients and their families, and not so beneficial in the long term in terms of managing cumulative blows, in terms of grief and losses. And, you know, a pandemic that has upended not just our professional lives, but our personal ones too. Because if we think back, you know, to the before times is what I'm calling them, you could have a hard day at work, but you could go home, it could be compartmentalized. You could say that was at the hospital or in my clinic, and home is hopefully different. But when you left the hospital, you were masked, you were physically distancing, you waited in lines at grocery stores and all the other things that might have kept you well, all those other activities, you know, whether it was, you know, sports, or, you know, going to the movies, whatever it was, you know, engaging in TIFF in the fall, all of the wonderful things that happen in the summer in Toronto, traveling, all of those things just came to a halt. And we struggled, I think, to adapt in healthcare in that beginning, to feel safe in our workplaces, and then to think about our personal lives as well. And I know if any of you are like me and you have school-age children, you were also elementary school teachers whilst running clinics from home. So a lot happening, recognizing too that many of us in healthcare are very privileged, in a very privileged position overall in society. And in spite of that, we too have suffered in this. And to find words for that and languaging for all that we have endured, and to begin to do some of the processing and the healing that'll be needed for us to move forward. So, moving forward. Now the slides have to move forward. So I don't know if some of you saw this. Adam Grant is like one of my favorite organizational psychologists. I think that if this psychiatry thing doesn't work out, that's what I'm going to do next. Either that or become a personal shopper. I can't decide. But you know, this article just went viral because I think it was so deeply resonant. You know, there's a name for the blah you're feeling. It's called languishing. And you can see in this picture, you know, psychologists tend to think of mental health in dimensional aspects. Often when we think of, how we were trained in the healthcare professions, you rely on the DSM, it feels sort of categorical, but we understand that there's a lot of nuance in between. And there are all of these feelings that we had that kind of meh, less delight, less drive, kind of indifferent, not excited about the future, feeling stagnated, especially, we're social distancing at home, apathy, kind of aimless joylessness, and how relieving it was for us to hear a word that was resonant with our experiencing. And, being a middle child myself, I like this line from the article: languishing is the neglected middle child of mental health. It's the void between depression and flourishing, the absence of mental health. And it was a term coined by the sociologist Corey Keyes. Why is it important? So going back to, if you can name it, you can tame it. For emotional regulation, so our more technical term, naming what you are experiencing is so important. The other piece of it in a relationship is having it validated and recognized by another person, which is so, so powerful in our regular relationships and of course in therapeutic relationships. And you'll see there's a Harvard Business Review article that I put that from the very beginning of the pandemic, so March 23rd of 2020. Think about that, how far we've come, how much has happened in that time. This is, I think, one of the most read Harvard Business Review articles. And who thinks HBR was the one to name this for us? That discomfort you're feeling is grief. That as the first wave of COVID hit, people couldn't figure out what was it that they were feeling. And it was grief and loss. And we've just had more loss in between. And so it's such a powerful experience to name, what's happening. That languishing may actually be more common than a major depressive disorder, that it is a risk factor for mental illness, that they've done some early studies, for example, in Italy that had a huge first wave, as you remember, that the healthcare professionals who identified as languishing in that first wave in the spring were 3 times more likely to develop PTSD later. And I like this, that is a refreshing foil for toxic positivity. That sense that we feel a pressure always to be cheerful and happy, and that we understand, in professional settings for our patients, that we do need to maintain a certain composure. But do we have safe spaces, now I'm aphasic, safe spaces for us where we can share in our workplaces, in our personal lives? And that, I think, became a bit more challenging too, as we were social or sort of physical distancing, and how relieved we will all feel when we can see each other in person and not just in boxes. So move forward to the next slide. So there is another side of languishing. We're not going to leave you with all the sad feelings, and that's flourishing. And that you can, regain a sense of well-being, and to know that this is an empirical field of study. So there's a Harvard Institute for Quantitative Social Science, which I think is so fascinating, in the Human Flourishing Program. And that, Tyler Vanderweel, who wrote this article on the promotion of human flourishing, has developed a scale as they are apt to do in these fields. But it really helps us, I think, explicate what do we mean by flourishing? What are the components of that? And what does that, how does that translate into things that we can do to promote a sense of well-being? So to take a step back first and think about a state of flourishing, that it relies on the WHO's definition of health as a state of complete physical, mental, and social well-being. And that I think it's really our effort towards that that's important, that often people feel overwhelmed about this mountain of well-being to climb, when we're coming from such a difficult place. To think about, this is an adage from psychoanalysis, that mental health is the capacity to love, to work, and to play. And I think that's so true. Love meaning having important relationships, close relationships in your life, how they buoy us, that there is literature about, the buffer in terms of our social supports, that the buffer that provides for us in terms of our wellness. Our work to feel productive, to feel generative, to feel like we're doing something important for meaning. And play, the analysts like to talk about the capacity for symbolic activity, but what does that really mean anyways? But it is that, capacity to be creative, to push boundaries a bit, to feel a bit sort of looser in what we're in our existence. And so we all have those, but, some of our areas of play were restricted during COVID. And so all of those usual avenues for maintaining mental health were challenged. In the flourishing measure, and you can do it online, it's free, they look at 6 domains, And you sort of reflect on, your overall sense of happiness and life satisfaction, your mental and physical health, the sense of meaning and purpose you have in life, your character and virtue, your close social relationships, and as Carla mentioned, your financial and material stability. That all of those sort of build on one another in terms of flourishing. So some tips in terms of flourishing, trying to savor the little things, taking a break, and appreciating the things that are around you. That often we had to sort of reformulate our goals, that we were looking forward to, a very elaborate trip or something like that. But that, for myself, I have started to savor the trails around Toronto. I didn't realize that there were so many trails to walk within the city. And so just taking a moment to stop and, feel a sense of gratitude, notice that in the moment for all the little things that we still have in our lives. Acts of kindness promote a sense of well-being as well. And they don't need to be big things. They can be small acts of kindness, foster a sense of well-being. And in the last one, the sense of community and connection. That's what I really wanted to focus on in this picture. And that we are so fortunate to have really strong communities of practice to which we belong, and to the bigger communities, outside of us. But that I know I felt fortunate for our inpatient medical psychiatry team. We actually still got to see each other, even though it was through masks. It was something in terms of human connection, that we all weren't sort of holed up and working from home, that we got to see each other and actually really talk to each other in person. And it made me realize how anchoring that was, being able to come into work, see people, talk to them, and also just go home and, feel really fortunate that I had my family there too. And so trying to savor all of these little things, that they're small steps in terms of maintaining your flourishing that become integral parts of your life. So they don't need to be grand gestures or really complicated things. And hopefully that's one thing that we take with us as we move forward and take stock of our experiences in COVID. So over to Susan.
So we're going to just do a final closing meditation to counter the negativity bias. So if you can do the next slide for us. Adrienne, I mentioned early on that, our brains have a negativity bias. And Rick Hansen, who's a psychologist, says the brain is like Velcro for negative experiences and like Teflon for positive experiences. And that is true for all of us. And it actually makes a strong evolutionary perspective. If you think about, is it better to make type 1 or type 2 errors? If we went back, a million years ago on the Serengeti, and there was an ambiguous sort of yellow round sort of shape in the distance, the folks that went, that's a lion, I'm going to run away, their genes got propagated. The people that went like, could be a lion, but it's probably a stone, nothing to worry about, they got eaten up. So that negativity bias is very prominent. And the good news, though, is that we can train our brains. We can train our brains through various forms of meditation, through gratitude journals, through taking those moments to find something that feels good. We've recently got a pandemic puppy, and I just cannot get over how fabulous it feels to go out the first thing in the morning and just feel the air kind of on my face and the world waking up. So we can consciously turn our mind to these more positive mind states that will bring us some relief from our suffering. So we'll do a closing meditation. If we go to the next slide, what I'd like you to do is to connect with a moment of integrity and congruence with our professional values from some time during COVID. So again, sitting, standing, eyes open, closed, not playing along if you don't want, but just taking a moment to think about something that has happened kind of during these COVID times that you really kind of feel good about, that was a moment that felt really aligned with who you are as a person, who you are as a healthcare professional. A moment where your values were really clear and visible. A moment where you felt that you had met your commitments and obligations. You had eased somebody's suffering. You'd been empathic. You'd shared a moment with colleagues, but some moment during these COVID times that has felt really aligned. A time that reminds you of all that is kind of good, and nourishing, and honorable about being a healthcare professional. And just taking a moment to just kind of bask in that feeling. You know, and maybe different things for different people, but whether it's a sense of warmth, heart connectedness, knowing that you were really doing what was important to you, knowing that you made a difference, either in the life of a patient or a colleague, a family member. That reminds you at your deepest core about the goodness that still resides within. And knowing that these moments, they're also there, and that we can always find them and we can use them to kind of find our feet after difficult experience. That they're a way to keep our motivation in front of us and to tap into that ability to be kind to ourselves, to others, to resource ourselves and our community, and to move forward in some new way with some added understanding from these times as we continue our work in healthcare. So coming back, and I don't know whether people are comfortable if you could add a word maybe of what that kind of what that is that you do carry forward, and kind of what that episode or that incident was for you, and we could just add that to the list. And then I think Adrienne is going to sort of open the floor, and we can talk about different kinds of flourishing, and I guess anything that people want to. We wanted to leave time today for people to talk.
Just some of the things that people are saying in the chat. So kindness, skill, self-sacrifice, hope.
And so important to remember that we do carry all these things, the good stuff in us as well, and that if we intentionally turn our minds to it, okay, we can reconnect.
So again, lightness, protection, hugs, grit.
I guess we're hugging again now. Outside of our circles.
That's great.
So, Susan, I have my hand up. If I could just say a few words. So first, I just want to thank you really on you all, Carla and Adrienne and Susan and the whole psychiatry team on behalf of the transplant program. I think this was much needed and perhaps just a first step. I personally feel that this pandemic. I know it's been hard on everyone, but I do feel it has been extra hard on the transplant program, because not only dealing with COVID, but dealing with, closure of our program and trying to look after all our sick patients who needed a transplant, and dealing with everything else at the same time. So, and as you know, this is one of the reasons we launched this whole investing in team transplant project, of which mental health is a big piece of it. And I think this is an important first step, what you've done here today. So very supportive. And I just want to thank you all on behalf of the program.
Thank you, Atul. I mean, I think it has been really challenging for transplant because, right, we've got such sick patients, and we want to get them transplanted, and to have the closures and things. It's been really. I'm glad I'm not you guys. I'm glad I'm not having those conversations.
You are us. You are part of us.
I'm part of you, but I'm not having to have these conversations with people explaining why we're closing down when they're so desperately in need. It's been really, and it's also been, I think you've all also had really challenging conversations. I've done sort of quite a few sessions for the CDTRP with the patient group, and the level of distress in the transplant patients and concern about getting COVID, how they're going to do if they do get COVID, what they can do to protect themselves. It's been really extraordinary.
Be interested in hearing other comments from people on the call as well.
Susan, can I ask a question? I think that, someone was talking about disconnect, and I think a lot of the learners probably feel a lot of disconnect with COVID. Do you have any recommendations on how, I feel like it's probably especially hard on people who are just coming in, don't necessarily have like the links and, some people who've been here many, many years, it's a little bit easier to, connect with other people. But for, say, like learners, fellows who are just coming in, just starting, having that feeling of a little bit of disconnect from like the transplant group, do you have any recommendations on how we could overcome that?
I think it's a huge issue, right? And a lot of them have moved across the world, and then they're suddenly here with nobody, and except their like little box of an apartment. But we're really lucky because in the secret life of Dr. Adrienne Tan, she's the director of postgrad education for the Department of Psychiatry at the university, and Carla Garcia is the director of undergraduate education at the Department of Psychiatry. So both of them are experts and learners. So let's see what they say.
So I can go first. Thank you for asking that question, Cynthia. It's such a, part of the challenge that the medical school has had is, that learners are really in that liminal space, right? I mean, this has been a really hard experience for young adults in general. And it's even more so when you're a young adult who's also trying to become part of a community that's in crisis, right? Which is sort of what they've been feeling. In terms of resources for your medical students, if you have any, I'm trying to remember how many medical students actually go into spaces in the transplant teams. The school has done a pretty good job of building community, and they do have a lot of resources, and the students you're getting should probably all be locals, because we haven't yet opened for international electives, and that's actually been part of the suffering. Again, U of T, we're a little lucky. We can provide our students with any elective experience they would like. That isn't true, unfortunately, for all of our colleague medical schools, but we can do that. And so that's sort of been built in. If you ever have a student who is in crisis, though, one of the things that is really important to do is you probably have someone, like if they're coming to you through a surgical rotation, let's say, there is a UHN site director for surgery who will be able to help you link that student directly to resources. And they have supports that have been built in specifically for students that are that have been made vulnerable for all the reasons we talked about today, right? Like they're far from home. They haven't been able to hug their parents for, a year and a half. And they are often, in really non-ideal circumstances, sharing spaces and stuff at home. So they don't have privacy, and then having to come to work and face different exposures. So that's been the way that we've managed that. Everything is very much co-located through the school. It all exists. They should know about it, but if they don't, ask them who their site director is, and they'll link them to the service.
Yeah, we're moving on, I think, to residents now. So yeah, we have about, I think, 200 residents over 5 years. And this PGY1 cohort, I think they struggled to really connect with one another. And so what they did was, payroll was giving money. And so they created something called PRNs, Psychiatry Residents Need a Break. And they were really creative with it. And they would do things. So like, because payroll gave them a bunch of cash, they bought, like, for example, cookie dough. I know it sounds funny, but and then they drove around and dropped cookie dough off at everybody. And they did a baking session on Zoom where they all like connected with each other and did fun stuff. I realized the residents love swag. So we bought them the fanciest monogrammed sweatshirts ever. Cause we had budget because we didn't do all these in-person, like Massey Hall, all this stuff, that those little things became really important to them, of symbols of the connection of belonging to that thing that's bigger than yourself. That we have taken extra care to sort of reach out. And, we're really lucky to have an active resident group. Our IMG, like a visa IMG residents who haven't been able to go home forever and ever and ever, we have given them some flexibility of like taking like 5 weeks off. Like if you need to self-isolate and go home, because that disconnection has been so hard on them. And I think that may be more similar to some of the fellows that you may have across it, but there's no, I think, getting around that. And I think the other thing we did is, now that we are fully PPE'd and feel comfortable in the hospitals, we tried to move all of our new residents into the clinical environment and not out of classes, because we knew they would see people and feel less isolated, and at least that they would get to know some of our faculty. And as Susan knows, we have a specific wellness curriculum for our incoming residents to help build some resilience and to support them in that. And so I think all of that kind of infrastructure is important in that. But yeah, it's finding all of those little things and allowing your trainees to be creative, because they often know how to connect with each other. And our emails of, are you well? Are you well? I mean, they just started after a while to be like, this is hard. So we tried to resource them to do things and to, and yeah, all of those little things. But yeah, the swag was really important. And I know we all proudly wearing our transplant swag recently, so.
And can you share your wellness curriculum, or?
Yeah, happy to do so. I think Susan has participated in it too. My very capable associate PD, Deanna Chacos, has led it, but we're happy to share it.
I was going to say, it's quite interesting, Cynthia. It comes from, there's a psychiatrist, Herb Benson, who for years and years and years has worked on something called the relaxation response, and sort of very brief vocal meditations to help people calm. And so he's developed it's 3 sessions of between 1.5 hours and 2 hours each. So you can kind of do it in 5 to 6 hours. And they do it in a group, and everybody gets there's a small cost for the workbooks. Everybody gets kind of a workbook. And then they learn some practical kind of de-escalating, calming, affectively regulating yourself, some skills. And also there's a great discussion on medical humor, and when it serves us well and when it doesn't. And a little bit about kind of how to reach out and connect with people when you are kind of from away. So it's been quite successful now, and I think we've done it. We're just going to start it again in July. This will be our 4th year of doing it. And we sort of usually lead it with a faculty member who may or may not have skill in it, because you can actually read it and sort of follow along, and then the chief residents.
Thank you.
I think a hand up from Les.
Yeah, I thought there was actually a hand button, but I can't find it. I'm just reading Nazia's note from a couple of texts ago, and at the risk of using medical humor, on a more sobering note, there's been a fair bit of collateral damage and that may have come up earlier, and I had to step away for a few minutes. And I think that the effects of this are going to linger for a long time. I had a endoscopy business unit meeting this morning, and they expect it will take 2 years to catch up on the lost endoscopies. It will take at least a year for the missing surgeries. And on the same note, my colleagues and I in the alcoholic liver disease program have seen an increase in referrals related to substance abuse during the pandemic. And so not just opioid use, which of course is on the news, but we've seen many patients referred who basically just kind of fell apart during COVID and relapsed to drinking and ended up in our hands. And some of them got transplanted, some of them didn't. So I think one of the things that we have to live with over the next year or two, even as things return to quote unquote normal, is that long-lasting collateral injury that we've seen, and that's going to take its toll in many respects. But again, thank you to my colleagues in the ALD program for weathering the storm with such good humor.
Thanks, Les. No, I think that's going to be that's kind of the next huge challenge that we're going to face, right? Is that it was interesting. I was talking to an internist yesterday who was saying that he just can't get over how intense GIM is these days. He said that, it used to be that he kind of liked his GIM rotation and time on the ward, and it was mostly problems you could fix or but now it just feels like everybody's coming in with this advanced pathology, multiple complexities, not being able to get investigations, trying to figure out what to do for them, that it's just overwhelming, and really concerned that particularly at large institutions like ours, most of us are here because we really like complexity, but too much complexity on top of all of this trauma and grief really has a risk of sending a lot of people away. So there are worries about, in the nursing profession, about lots of people retiring early, or getting out, younger people not staying in the field because it just feels too hard. So we are going to have some challenging times ahead, and I think we really have to take care of each other and kind of work on our own resilience. Although it's going to really help to be able to go out and have a nice meal on a patio.
Yeah.
Any other comments? Well, maybe we can give everybody the gift of time and just go off and just have 5 minutes to yourself before you start your busy days. And truly thank you so much for coming today, for taking part, and for all you do. It's incredibly challenging, but also such important work. Thanks so much.
Thank you,
Thank you so
Susan.
much.